is Ali Hassan, and today our topic is syncope. All right. I feel like this is a very high yield topic, especially when it comes to differentiating between different types of syncope, between syncope and seizures. And these are very important concepts. So we'll just start with these terms. What is loss of consciousness? Loss of consciousness is basically absence of self awareness and or the awareness of surroundings. Okay. And what is transient loss of consciousness? That's basically just a temporary form of loss of consciousness. Then what is syncope? Syncope refers to a sudden and rapid loss of consciousness, followed by a spontaneous recovery, and it is believed to result from insufficient blood flow to the brain. Now, this is important, insufficient blood flow to the brain. How are you going to differentiate loss of consciousness from syncope? Insufficient blood flow to the brain. Okay. Now, we also have to differentiate syncope from pre-syncope. Pre-syncope refers to symptoms that precede syncope, such as lightheadedness, visual symptoms, and potential altered consciousness, not loss of consciousness. Okay, so these symptoms may or may not progress to syncope. So it's uh, basically the things that happen before syncope, but they're not always going to result in syncope. Okay, so the next slide is syncope versus seizures. Now, this is something very high yield, and these are important concepts because they can I saw this from a layman's point of view during and, during my preparation, and I struggled with this because they are very similar. Okay, so how do we differentiate seizures from syncope? You might think that someone is losing consciousness and there are a few muscle jerks and everything, so that's definitely going to be seizures. Okay, but that's not the case. That's how they trick you. Okay, so first of all, what happens in seizures? There are preceding features. Patients may have an aura or a warning, but in syncope, there are also similar things that are happening, like lightheadedness and dizziness. These are prodromal symptoms. They do not happen in all forms of syncope, but again, the point is that preceding features, until unless there is a very specific aura or something, you cannot. It's not a very good differentiating point. Okay, until unless there's a very specific aura. Okay, then positioning is important. When we'll go forward, I'll teach you guys vasovagal and cardiac syncope. So and again, this is not a very good differentiating factor, but like cardiac syncope and seizures can happen in any position. All right. So yes, then we have tongue biting. Now this is a very big hint in questions. Uh, how are they're going to give you the picture of syncope. They're first going to give you many pictures of seizures, and the answer is going to be syncope. But then they're going to trick you by adding tongue biting to them. If there's tongue biting, that is a seizure. All right. So you need to be aware of this. Okay. And this is, please remember this, tongue biting is very important. Okay. Then we have convulsive movements. Convulsive movements. Okay. Okay. Convulsive movements can be a very big confusion. Okay. Again, we as a layman attribute this to seizures, but they can happen in syncope. The differentiating factor is the convulsive movements in seizures are going to be tonic clonic, means like they involve both hemispheres, and they're going to be like these. When you're doing a question, you have 1 minute. Uh, it's not easy to differentiate whether this is a seizure type movement, or is this just like a brief myoclonus. Okay, so how are we going to differentiate that? I would suggest that we differentiate it this way. Okay, because in 1 minute it is very it gets complicated if you get into the details of the movements. So during seizures, the convulsive movements occur before or simultaneously with the loss of consciousness. Okay, this is important. While in syncope, these movements occur after the loss of consciousness. These may be jerks or myoclonus. They are again brief, but I would not suggest you guys to get into too much detail whether they are brief or not, because it's a very gray area. But what is not a gray area? That is convulsive movements occur before or simultaneously with loss of consciousness and seizures. All right. Urinary continence can also be a good differentiating point. Again, they can occur in both of them. They're rare in syncope, but they can occur. Okay, so how are you going to differentiate that? Again, the same way. Uh, in syncope, urinary incontinence occurs after the loss of consciousness. Okay, so now the last thing is post episode recovery. So, as we all know, there uh, we have post-ictal states in seizures, but we can also have that in syncope. It's not called post-ictal phase, but it is, it is similar to that. Because obviously the blood flow to your brain has been cut off, so there is going to be some confusion left after that, but that only lasts for like 1 or 2 minutes. And the residual confusion, which can stay for minutes to hours, even days in seizures, does not appear in syncope. All right. So these are the three things. Again, I'm going to say tongue biting, convulsive movements, the timing of convulsive movements, the timing of urinary incontinence, and the duration of post episode recovery. Okay. You have to understand this. And if you guys have any questions, I'll take it after the class. Okay. Towards the end of the class. So, yeah. Okay. So, we are going to break down syncope on the basis of etiology because this way it gets easier. So first we have reflex syncope. Okay, then we have orthostatic syncope. Then we have cardiac syncope. All right. So vasovagal syncope and situational syncope. Now this is a bit of a tricky, uh, uh, tricky topic because because of the because how it happens. Like vasovagal syncope, these basically happen due to a autonomic nervous system trigger. Vasovagal syncope can happen due to emotional stress, prolonged standing heat, emotional stress. uh, One example of vasovagal syncope is like after someone gets into a race, and a race or like a match or something, and there's a lot of heat, and suddenly the vasovagal responses stop. And no, they don't stop. It's a bit complicated, but this is an example of vasovagal syncope. Now situational syncope can happen due to pain, maturation. Like an example of it is hair combing, especially in children. It can happen during straining of defecation. So we need to understand like the difference between vasovagal and situational. The management is not that different, but still like we can differentiate them based on examples. All right. So how are they going to present? Now this is one single point that I want you guys to remember. Vasovagal syncope is preceded by a prodrome. Okay. And now that prodrome includes pallor, lightheadedness, nausea, and followed by a rapid recovery of consciousness. People may also exhibit bradycardia because of the vagal response. Now, please focus on this. The prodrome is important, all right? Uh, because this is a very unique feature. And when we move to cardiac syncope, I'll please remember this so we can differentiate that particular uh, syncope with this. And obviously, vasovagal syncope, when there's a problem in the body, that your vagus nerve, your vagus system gets triggered, so that's going to happen again and again. That's the same thing that's going to happen in situational. So patients often have recurrent episodes. Okay, the prodrome is again only for vasovagal syncope, not situational syncope. Okay, so keep that in mind. Okay, so management, the diagnosis is clinical. That's why all the points, the presentation, why I was focusing on prodromal symptoms was because we are going to diagnose this clinically. Okay, so when the question comes, are we going to do an ECG or for that or something else? Are we going to do the tilt test for like we do for orthostatic syncope? No, the diagnosis is clinical. Okay, so this is also one type of question. So please, you have to be smart. Okay, you have to you have to be strong on your concepts, and the diagnosis is clinical. And believe me, it's very frustrating when you're thinking all of the things and the answer is clinical diagnosis or do nothing for diagnosis. Okay, no intervention required. So please keep that in mind. And for patients with recurrent syncope, We have to counsel them. We have to advise them to avoid triggers. Okay, like standing in heat for a long time and everything. Okay. Uh, Physical counter pressure measures. These are basically maneuvers uh, that help you go through this phase. So you keep doing them, and that's how you counter uh, uh, these types of syncope. Okay, like leg crossing with tensing of muscles, hand grip, tensing of arm muscles. Basically, you lose your the vagus nerve is supposed to decrease the blood pressure and everything. So you have to do measures uh, that increase the blood flow to the brain. Okay, there was I also it's not written over here, but there was this measure where a maneuver where you raise your legs and like the blood flow to increase the blood flow to the brain. Okay, so these are all. You do not need to know every one of them, but you just need to have a grasp of the concept. Okay, what does hand grip do? It increases the blood pressure. Okay, so you just have to understand why we are doing this. That's it. Uh, Again, during the prodromal phase can improve venous return and cardiac output, sometimes aborting syncopal episodes. So, yeah, so it is a very uh, it is just basically counseling. And if the patient, this is not very important, but some patients in high risk settings like pilots and everything, if they have vasovagal syncope and they get syncope, so the passengers are dead. All right, so we counsel them to restrict their activities until these maneuvers are proven effective. Okay, that makes sense. Again, this is not very high yield, but if the systems persist, we use fludrocortisone. Okay, it's a steroid. So yeah, I hope all of this is clear. Uh, now the third cause of reflex syncope. Okay, that is carotid hypersensitivity. Okay, now this is a specific one. So we have separated it. Now the etiology involves tactile stimulation of the carotid sinus. Okay, this usually happens in people with hypersensitive carotid sinus. Like all of us have the carotid sinus located in a neck or something, right? But it's not going to happen to all of us. It only happens in people with hypersensitive carotid sinus. And one of the risk factors for a hypersensitive carotid sinus, secondary to atherosclerosis and advanced stage. Okay, so that pretty much makes sense. Okay. It happens in events like shaving, tightening a neck collar, massaging. Like these are classic examples. And the management again involves counseling the patients to avoid triggers like do not wear tight collared clothing. Consider a pacemaker for patients with carotid sinus syndrome with a cardio-inhibitory response. Now, this is not very important and this is not tested, but I just thought that we'd mention that. Okay, so we are moving on to orthostatic syncope. All right. There are three causes for orthostatic syncope. What is orthostatic syncope? Orthostatic syncope क्या होता है? It's basically your blood pressure is dropping when you're standing. And why is that going to happen? Either you do not have a very effective autonomic nervous system, sympathetic system. Either you do not have the volume, okay, or the volume like you have lost a lot of blood, lost a lot of fluids through diarrhea or something, and now when you stand up from sitting, the blood is not reaching your brain because it's all because your counter systems are not working in the body. Okay, so first, the medications like vasodilators, alpha one blockers, etc. They prevent the arterioles and everything to constrict. Okay, so the blood is going to pool in the legs and it's not going to reach your brain. All right. Then come inotropic and chronotropic blocking agents like calcium channel blockers. Even if the blood reaches your heart, it's not going to be able to pump that quickly uh, through the sympathetic response, and so that the blood reaches your brain. Again, you have to. It's common sense. Okay. Hypovolemia. I already told you. Like we do not have any efficient volume to reach the brain. And autonomic dysfunction. This happens with advanced stage predisposing CNS or ANS disease like Huntington's, Parkinson's. I also have to mention diabetic patients when they have autonomic neuropathy. So this happens in them. So since it's a very common patient population, so I'm just going to mention it over here. So now medication and hypovolemia. Again, I've explained all of this to you. Standing up position. Then there is insufficient compensatory response, reduced heart rate and narrowed blood vessels due to autonomic dysfunction and external factors, blood pools, low blood pressure. Okay, simple. And this can happen with or without symptoms, but sometime eventually it's going to happen with symptoms. So yeah. Management. So the diagnosis. Now this is important. Orthostatic hypertension, basically when you change from a supine or seated seat to a standing or upright position, the systolic blood pressure decreases by more than 20 mmHg, more than equal to, or diastolic BP decreases by more than or equal to 10 mmHg. Okay, these are values. You have to remember this. I will give you the presentation, but it's not that hard because just think of it as like systolic BP is always higher, so 20 decrease is required, and diastolic BP is lower, so 10 BP decrease is required. All right. So yeah. Then what we have to do for this? How do we manage this? Uh, we depending on the situation, we are going to enhance the fluid consumption for someone who doesn't have enough fluids, hypovolemic. Okay, we're going to increase the sodium intake so the blood stays in the vessels. Okay, we're going to increase the osmolarity until unless contraindicated, like for example if someone has kidney disease, liver disease, cirrhosis, so we are not going to overload them with volume. Okay, obviously if it is happening due to medication, we are going to modify the medications. We depending on the situation, that's a clinical decision of uh, what's the what's the positives and how much loss are we facing. So again, yeah. So autonomic dysfunction, I already discussed advanced stage and predisposing CNS disease presentation. Autonomic dysfunction impairs or blunts the reflex tachycardia or vasoconstriction. Pathophysiology is same as the orthostatic syncope that I've explained above. What is going to be the management of autonomic dysfunction? Okay, we just have to treat the underlying condition because we cannot do anything else. So, yeah. Uh, we obviously if someone has Parkinson's or diabetes, so he must be on multiple medications, and some of them might cause some alpha blockade or sympathetic blockade or something. So we obviously are gonna look towards that. Again, and the next two points are not that high yield. They are not tested. I haven't seen them tested. The primary options are again steroids, midodrine, droxidopa. For resistant symptoms, we give pyridostigmine or octreotide. Again, these are not tested. I've just mentioned them over here. So the last type of syncope is the cardiac syncope. Again, I'm telling you guys, this is a very small topic, but it is tested. Okay, and the concepts you're going to use these concepts, and because there's a touch of neuro, there's a touch of endo. So the test makers, they love topics that touch multiple disciplines. So okay, so LVOT, left ventricular outflow obstruction. Okay, examples are aortic stenosis and HOCM. HOCM is hypertrophic cardiomyopathy. In HOCM, basically the outflow from the left ventricle is a bit obstructed. Okay, so how are you gonna find out like this is left ventricular tract obstruction? Simple. The presentation is gonna include syncope with exertion. Okay, if you've done aortic stenosis, you must remember that the mnemonic is SAD, syncope, apnea, dyspnea. Okay, syncope. I don't remember what A was, but S is for syncope, D is for dyspnea. So this all happens with exertion, and we will obviously have a systolic ejection murmur. That's classic for both aortic stenosis and HOCM. Okay, the second cause of cardiac syncope is ventricular tachycardia. It can happen due to a already predisposing cardiomyopathy or ischemic heart disease, or it can also happen due to QT prolongation. The QT prolongation one is going to be polymorphic, and the cardiomyopathy or ischemic heart disease one is going to be monomorphic. Now, if you do not understand this, you'll probably understand this towards the end of your journey. But and these forms of tachycardias, yeah, I'm not going to go into detail today. Okay, so ventricular tachycardia, there are no warning symptoms. Okay, it can happen kabhi bhi, like anytime. There is usually evidence of underlying structural heart disease. Okay, prior MI, murmur of MR or something. We'll have something, and we will also have presence of frequent ectopic beats. So these are important clues. All right. Then we have uh, the third cause of cardiac syncope. conduction impairment. This is a very vague term and a very big term. So a lot of things can come in this. We will have ECG abnormalities. Okay, so this is what I was referring to you guys in the start when I was mentioning the prodrome. The presentation is going to include preceding lightheadedness and fatigue. Okay, you have to differentiate this between this and the prodrome. This has no feeling of warmth or pallor. Okay, so this is the differentiating factor between this and the prodrome seen in vasovagal syncope. All right, guys, you have to be smarter. All right. So what's going to be the management? Okay, this is the management of every cardiac syncope. Okay, we have to treat the underlying cause. We have to implement continuous cardiac monitoring for patients. Now, this is not tested, but if the patient is less than 40 years old, we usually use Holter monitors or 24-hour monitors for the ECG and everything because VTAG is not going to happen always. ECG abnormalities are not going to happen always. So we we keep them because if a patient comes after syncope and the ECG is normal in the hospital, so are we just going to exclude it? No, we cannot because that happens kabhi bhi, and like there's no uh, you're less likely to catch it. Okay. Uh, so the other diagnostic procedures are okay. Sorry, if the patient is more than 40, then we usually admit them for assessment, and we like keep track of that. Okay. So again, this is not a very high yield point, but you should just keep that in mind, and just in case you should know this. Okay. Diagnostic procedures such as endoscopy, CT angio, lab tests, you obviously are gonna rule out everything possible because this is not just a random thing that happens like vasovagal syncope or something. So you have to rule out the other cardiac causes. Okay. So in the end, I have made these tables for you guys. These are all the things that we have covered, but this is going to help you. These tables are going to help you a lot to exclude uh, to exclude wrong answers and everything. It's a very good tool. Okay. All these tables. So I've used multiple resources for that, and that's my lecture for today. If you guys have any questions, you can ask me right away. You guys have any questions, guys? Okay, is if you guys do not have any questions, thank you, Raj. Uh, then I guess it's clear to all you guys. This will be posted on our page. So yes, I enjoyed having you guys. Hopefully, you learned from today, right? So bye, guys.